A very good evening to one and all. I am Arpita, today's moderator from the IGCP group. So I will be moderating the session today. The topic for today is diagnosis and management of arthritis by primary care providers. And yes, to describe the topic, to go ahead with the topic, we have with us none other than Dr. Suresh. Dr. Suresh is a family physician, public health consultant from Bangalore, and a visiting professor of practice from the KSRTRU, Karnataka. He has completed MD, DIH, DF, FIAP, FIPHA, FISCD. So, with this introduction, I would request sir to please start with the session. Over to you, sir.
Good evening, friends. This is Dr. Suresh. I'm basically a public health specialist, but after my retirement from UN, I'm doing a family physician tasks. Today, we are talking one of the common conditions which most of general physicians, including me, are likely to see in routine practices. In general term, we call it arthritis. Very often it is felt next, Ankara next. When we say arthritis, as you know, it's just a generic term which just refers to inflammation or degenerative change in a joint that leads to the swelling and tenderness of the affected one or more joints. The commonest of these diseases are known as rheumatisms, which generally affect neck, back pain, fibromyalgia, and osteoarthritis. These diseases are most commonly prevalent among what we call the productive age group of 30 to 50 years. They occur more often in females, both in rural and urban populations, and they account for considerable disability of 20% or 1 in every 5 people, leading to a loss of livelihood and dependence on others for self-care. The usual joints affected are knee, feet, hands, hip, and lower back. This is one of the most bone and muscular condition which affects people over the age of 65 years. Next. Ankara next. Now, what is the role for a primary care physician like you and me, or smaller setting hospitals? Basically, we call the family or primary health care providers are the gateway of helping arthritis patients. As you know, arthritis patients in India see more than one specific care provider, which includes from untrained, untrained, trained basic graduate of all systems of medicine, that is homeopathy, allopathy, Ayurveda, naturopathy, etc., and even the specialists at the district and sub-district level. When we go to the urban cities, bigger cities, nowadays we have access to surgeries, most common being robotic surgical intervention. Here, patients go directly, decide on their own, therefore they go without any gatekeeping. Generally, we expect about 10 to 12% of our outpatient are due to the rheumatic and musculoskeletal diseases, and in the hospitals where there are inpatient, particularly second and tertiary care of hospitals, 10 to 12% of the patients belong to this group. As far as the general goal of arthritis management by a physician is to reduce symptoms and improve the quality of life. However, the current thinking of primary care practitioners, which basically means one doctor, may have to be expanded to include pathways such as diagnostic support, physiotherapy, and a proper referral system. Next. So, what is it that we see generally in our practice? The most common types of arthritis seen are osteoarthritis and rheumatoid arthritis in adults and elderly population, and rheumatic arthritis with fever in children. In osteoarthritis, there is a change in the cartilage, which you know is a hard, slippery tissue that covers the ends of the bone at any joint which breaks down. On the other hand, rheumatoid arthritis is a disease in which the immune system attacks the joints, beginning with the lining of the joints, most common affected, as already told, knees, feet, hands, hip, and lower back. There are other conditions like gout, which is due to the uric acid in our blood. Sometimes infections or underlying diseases such as psoriasis, lupus erythematosus can also cause the other types of arthritis. Children, we already told, rheumatic arthritis is the common due to streptococcal infections. Unfortunately, it is prevalent in developing countries, including India, even in 2024. Treatment of, in generic sense, depends upon the type of arthritis. The main goal of treatment, as we already told, is to reduce, improve, and improve the quality of life. Next. Next. Now, this is a common visual example of the type of arthritis we classify. One is known as degenerative or mechanical. Then there are inflammatory arthritis, childhood arthritis, chronic connective tissue diseases. We'll talk each one of them in the next few slides. Infectious arthritis, metabolic arthritis, and septic arthritis. Next. Now, as a practitioner, I would use generally what we call as Oxford knee score. This is called, can be used for any joint, but basically called knee joint score because most often the joints are affected. So this has our 12 questions where we give the marks of this. Each question you can see there are 5 possible answers. So they get the numbers of 4, 3, 2, 1, and 0. At the end of 12 questions, you can see questions which include basically a description of the pain by the patient himself, which says pain is none, very mild, mild, moderate, or severe. Second question talks of, have you had any trouble with washing and drying yourself all over because of your knee joint? Again, here there are 5 options: no trouble, very little, moderate trouble, extreme difficulty, and impossible to do. So the score goes again 4, 3, 2, 1, and 0. The next question talks of any trouble getting in and out of the car or a public transport, whichever you generally use. Again, here it talks of no trouble, very little trouble, moderate trouble, extreme difficulty, impossible to do. The fourth question talks of, for how long have you been able to walk before the pain from your knees becomes severe? No pain at all. It takes more than 30 minutes to pain to start. It takes just less 16 to 30 minutes, 5 to 50 minutes. I can walk around only the house. There is impossible to walk. So again, the scoring is 4, 3, 2, 1, 0. Fifth question talks of, if you're sitting on a table for your lunch or dinner, getting up from the table or the chair, how painful it has been to stand up from the chair because of the knee joint. The options here are not at all, slightly painful, moderately painful, very painful, and unbearable. The sixth question, have you been limping when walking because of your knee? Rarely or never, sometime, just at first, then often, not just at first, most often the time. Again, the ranking here is 43210. Next. The seventh question asks, could you kneel and get up again afterwards? Yes, easily, with little difficulty, with moderate difficulty, with extreme difficulty, no, impossible. Again, marks are 43210. Have you been troubled by pain for your knee in the bed at night? No nights, one or two nights, only some night, most night, every night. Again, ranking is 4, 3, 2, 1, and 0. The ninth question asks, how much pain from your knee has interfered with your usual work, including the household work? Again, not at all, a bit, moderately, greatly, totally. The marks we give are 4, 3, 2, 1, 0 in that order. Basically, it's from left to right. The 10th question asks about how did you feel your knee might suddenly give away? Have you ever felt that will let you down? Rarely or never, sometimes, just or just at first, often, not just at first, most often, and all the time. Could you do the household shopping on your own? Yes, easily, with little difficulty, with moderate difficulty, with extreme difficulty, no, impossible. Could you walk down one flight of stairs? Yes, easily, with little difficulty, with moderate difficulty, with extreme difficulty, impossible. So when you ask these 12 questions, you will be ranking. Please note, this has to be asked if more than one joint is involved, for each joint separately. Next, please. So now we score these questions as I told you, and then if the total number is less than 19, we say the condition of the patient is very poor. 20 to 29 is supposed to be moderate problem. 30 to 40 is perceived to be good, but may need some pain reliever. And anything more than 40 are perceived as excellent knee position. If we use this tool, it's easy to diagnose and also manage and monitor the progress. Next. Now, these are other way of classifying if you have an access to X-ray or MRI or scanning, which is known as scale grading or Kellgren-Lawrence grading scale. When there are no features of osteoarthritis, it is normal, as you can see in picture 1. Grade 2 is a doubtful where there is a minute osteophyte, therefore it is doubtful significance. And grade 3 and 4 are mild, where there is a definite osteophyte, normal joint space is reduced, as you can see here. And when grade 4 is severe, where the joint space is greatly reduced, as you can see, there is hardly any space here. Unlike here, there is a space up to here, and there is a blockage here. So this is also known as what called as a subchondral sclerosis. Next, please. So for a clinician, there are few indicators we need to use. First is called as clinical indicator, whether polyarthritis, that means involvement of more than 4 joints. Inflammatory arthritis with symptoms worse in the morning and improving as the movement starts for the day. symptoms persisting for more than 6 weeks. So we need to see these three basic indicators. Again, involvement of joint more than 4, signs of inflammation, either redness, swelling, pain, etc., which is worst in the morning, and as he starts moving, he or she starts moving, it improves. And any symptom persisting for more than 6 weeks is called chronic arthritis. As you know, laboratory tests in the routine, we do rheumatic factor and what is called as anticyclic citrullinated peptide factor antibodies positive. This generally taken as confirmation of rheumatoid arthritis, but in 10% of the cases, we call that seronegative rheumatoid arthritis. This may not be positive. In the current day, the confirmation usually depends upon visualizing synovial inflammation by ultrasound or MRI. We know ultrasound is easily available now and happens to be cheaper. Next. But there is a commercial market, going on. Sometimes a battery of tests are asked. As a general physician, you may not try to do this, but you must be aware that if they go to the tertiary center, these are just blood testers like biomarkers, ESR, CRP, and CBC. What they do is they hint at the inflammation and are maybe guiding in certain types of arthritis. Blood culture may include rheumatoid factor, anti-CCP, anti-nuclear antibody, creatine kinase, cryoglobulins, and HLA-B27. Imaging, as I told you, is the mainstay nowadays in most of the places above taluka level and even in some taluka level. MRI and CT scans are advanced imaging techniques, as you know. They can visualize the cartilage damage and bony erosions, providing crucial insight to the disease and severity. Of late, musculoskeletal ultrasound is also being used, which gives us the real-time images of soft tissues around the joints. This technology, as I told you, has gained a lot of popularity, being a non-invasive, and it has an ability to detect early signs of inflammation and structural changes. Arthroscopy, direct arthroscopy is rarely done nowadays, but that is also one way of looking at it. Is an invasive, as you know, but allows a highly detailed inspection of the joint, aiding both diagnosis and treatment planning. Synovial fluid analysis, or called as arthrocentesis, extracting and analyzing the synovial fluid from an affected joint can provide biochemical markers for arthritis. This test helps differentiate arthritis, making it easy to tailor-make the treatment strategies for the individual concerned. Next. And now this is one recent study of 2019, which is known as Global Burden of Musculoskeletal Complaints. You can see we have about 131 million, 1.3 million, that is 13 lakh people with complaints, and the annual prevalence is about 3.35 lakhs cases every year. Adding to that, the disability adjusted life years lost due to these diseases is equal to 13.6 lakh years. Deaths due to musculoskeletal complaints have progressively increased between 1990 to 2019. Over 30 years, it has gone up by 40%. The major conditions listed here are low back pain, followed by osteoarthritis, mostly knee, neck pain about 2.3 lakhs, 3 lakh, rheumatoid arthritis, gout and other disorders. Low back pain is a leading cause of disability beyond the age of 10 years and it is maximum in the age group of 25 to 49 years. Other complaints include neck pain, rheumatoid arthritis, osteoarthritis and gout which cause between 25 and 74 and maximum around the age of 40 years. Next. Now we quickly go through a list of common conditions. First comes the degenerative or mechanical arthritis. This is an assortment of illness together referred to as degenerative or mechanical, primarily entails harm to the cartilage that surround the ends of the joints. This kind of arthritis causes cartilage and which has the primary function of facilitating easy gliding and motion. Therefore, the joints become weak and roughen. But human body starts remodeling the bone to restore the stability to make up the cartilage loss, and you can see the changes in joint function and the person's position in walking. Osteophytes, which are unwanted bony growths, form as a result of joint misalignment leading to osteoarthritis. Osteoarthritis may also develop because of the joint injuries such as fractures or inflammation. Second set is what is called as chronic connective tissue diseases. Here, as you know, connective tissue has a function of supporting, uniting, dividing our bodily tissues and organs. Connective tissues are, for example, cartilage, tendons, and ligaments. Any of inflammation of any of these things leads to joint discomfort. You also know the connective tissue disorders occurs mainly in skills, muscles, lungs, kidneys, in addition to the joints. It may also affect lungs and muscles, which will give signs of arthritis. Some of the examples include lupus or systemic lupus erythematosus, systematic sclerosis, dermatomyositis, and also cause of sore joints. Next. Next, Ankana. A little more about rheumatoid arthritis because this is the commonest thing which we see. Basically, as we told, this is an autoimmune disease primarily affecting the synovial portion of the joints, unlike arthritis, which affects cartilage. So, spondyloarthritis affects tendons. Here, this is basically synovium which is used, and it is an autoimmune disease. Here, it involves T and B cells which interact and produce what are called as cytokines, which signals causing inflammation, pain, swelling, and fatigue. As we already know, rheumatoid factor is often usually diagnosed late, leading severe joint damage by the time the patient seeks help. Diagnosis depends upon either using the clinical signs of polyarthritis, inflammatory arthritis symptoms which worsen in the morning and improve as the day passes, symptoms persisting for more than 6 weeks. Laboratory tests we already learned, rheumatoid factor, anti-CCP antibodies are may be diagnostic and called for. But most often, currently diagnosis is based on visualization of the synovial inflammation by ultrasound and MRI. Ultrasound, of course, is the cheapest source available widely in India, even up to some taluk level. Treatment, in principle, what we do is we block the cytokines phenomena. Common drugs without is methotrexate is the gold standard, weekly in the range of 15 to 30 milligram. It reduces the inflammation. It is well tolerated but may cause nausea in some patients. Some other drugs include sulfasalazine, hydrochloroquine, and gold injections. Hydrochloroquine is given in 30 milligram daily. It's safe, used for long term, but need to monitor the retinopathy in eyes. Sulfasalazine is effective given daily but can cause gastrointestinal issues and also can reduce the sperm count. Lefenomide is another daily medication, but it has a higher risk of liver toxicity. Therefore, one need to monitor liver function and kidney function test if you are giving them. If above traditional medicines do not help, there are what happens is there are anti-tumor necrotic factor drugs, anti-TNF drugs like infliximab, which are called a target and inhibiting drug, which are responsible for reducing the cytokine and inflammation. Sometimes we use what are called a JAK inhibitor. These are both when the top traditional and biological drugs fail, one may use small molecules called a Jonas kinase inhibitor, JK inhibitor in short. The names of the commercial drugs are tofacitinib and baricitinib, given orally as a last resort. They also do the same work of minimizing the specific cytokine production and thereby the inflammation. They do have the risk of result giving the side reaction of TB or tuberculosis and herpes zoster and thrombotic episodes. One has to be careful if one is using. Next. Next. So these are the 2-3 conditions shown picturesquely. Basically, osteoarthritis is mainly in joint. Rheumatoid arthritis is more in smaller joints, and gout is basically in big toes, you can see. Next. Next. Now we come to the second category of inflammatory arthritis. Here, there is an inflammation which is not obvious immediately, but has a typical process of inflammation. If we take preventive measure against germ and viruses, and it may be a reaction to the wounds like burns or other injuries. The damage caused by this inflammation results in discomfort, stiffness, swelling, counterproductive and harmful to the afflicted joints. Multiple joints may be affected by inflammatory arthritis, and the inflammation can harm both the bone under the skin and the joint surface. Rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis and childhood arthritis are some of the examples of the inflammatory arthritis. The most typical kind of arthritis is called, in children particularly, called as juvenile idiopathic arthritis. There is no treatment for this. It can permanently damage the joint. Remission, on the other hand, is possible, occurs when the illness is dormant. Immune system is blamed for this condition. Next. Next. Infectious arthritis. Go back. Metabolic arthritis. Yes. Continuing the inflammatory, inflammation can become into infectious due to infection by bacteria, viruses, or fungi. The commonest organisms are Shigella and Salmonella, or sexually transmitted diseases like gonorrhea and chlamydia, hepatitis C, which is caused by blood transfusion or shared needles. If the infection is not treated early, the arthritis can turn chronic and result in irreparable damage. Septic arthritis is an infection, either bacterial or fungal, most often in hips and knee joints. In India, it affects about 2 to 6 persons for every lakh population. A joint may get infected by a microbe directly through an injury or surgery, or getting infected by other disease causing germs which travel to the joint through the blood. Most of cases are acute septic arthritis caused by staphylococcus, and Neisseria gonorrhoeae. Chronic septic arthritis is caused by Candida albicans and Mycobacterium tuberculosis. Of late, septic arthritis has increased because of joint injuries, illness, and the inserts for artificial joints. Infection anywhere else in the body can also attack any joint, as I already told. Drug usage by injections like intravenous or for lower immune functions, and recently induced joint or arthroscopy or other surgery of a joint in old age are also likely to lead to septic arthritis. Since this has an ability to quickly destroy the joint, it is called as rheumatologic emergency. It could be fatal also. So one needs to be careful. If you suspect sepsis, refer urgently. Next. Next. So metabolic arthritis is another condition which we usually call as due to purine containing compounds, a chemical. This is most of it gets dissolved as a uric acid in the blood and carried to the kidney and excreted through the urine. But in some people, either the production is more or the excretion by the kidney is low. Therefore, a buildup of uric acid results in the formation of needle-like crystals in the joint, which causes rapid spikes in the level of acute joint pain or a gout attack. If the amounts of uric acid are not lowered, gout can either develop into a chronic condition or occur in multiple episodes. As I told you, big toe and hands are the typical joints that are affected in gout, along with few other small joints. Next. Next. Another common condition in Indian population, particularly among the women and elderly, is osteoporosis. According to the Indian Society of Bone and Mineral Research, osteoporosis is there in about 20% of the women and 8 to 25% of men over the age of 50 years. A study of 792 males and 808 females who were older than 50 years in urban New Delhi recently reports that osteoporosis of 35% in general, 25% in male and 42% in females. Osteopenia is about 50%, 54% in male and 45% in female. Similar studies across the country have shown the ranges of osteoporosis in 20 to 30%, one in Hyderabad, second in Vellore in Tamil Nadu, and osteopenia, that is, osteoclasts are low, the bones are weak, is in the tune of 47% of the spine and 53% of the femoral neck. Therefore, the fractures are likely to occur in these sites. Next. Now we go according to type of cases we are likely to see in the type of patients we see. We start with how the children may come to us. Arthritis among children is basically juvenile idiopathic arthritis. This is the most common cause among children less than 16 years and lasting 6 weeks or more. It causes both short and long term disability. There are four major types identified. One is called as enthesitis relatus arthritis, GIA. Nearly one third of them are enthesitis related arthritis. Second is called as polyarticular GI. Here, more than five joints are involved, and they are again nearly around 28%. Systemic GI, also so GI. Here, apart from joint pain, there is fever, rash, and large lymph node enlargement, which is again of the similar range of 27%. And oligoarticular, where less than four joints are involved, or marginal, about 9%. The treatment are usually the conventional synthetic disease modifying anti-rheumatic drugs. We will come to that. They are short known as DMARDs. Some of the children with SOGIA and polyGI and ERA may need biological disease modifying anti-rheumatic drugs called as BDMRD if they are refractive. We will come to this treatment part again. Rheumatic fever, is connected with the leading to heart disease also. Yes, we know this is a systematic illness caused by group A beta type hemolytic streptococcal, shortly known as GABHS. Starts from pharyngitis or sore throat in children. The incidence of acute rheumatic fever throughout the world is about 8 to 50 per lakh population of children aged 5 to 15 years. Worldwide, conservative estimate are about 470,000 new cases annually. These joints, as you know, are mostly affecting large joint, usually knees, ankles, elbows, and most important is fleeting in nature. That means it starts in one joint, moves to the next, and to next, and next like that. All of us who are in practice know this. In India, while in America about 3 lakh children annually suffer, in India many studies have indicated as low as 12 cases to as high as 450 cases per lakh population in the age group of 5 to 15 years. Next. Now we look at among the reproductive age group, that is what we call as people who work hard. You can see here the most commonest arthritis among people between the age and 40. This is the beginning always. And we also know women suffer more than men. Osteoarthritis is the commonest type, where we already know it is the cartilage that gets affected. So you can see the cartilage here getting erosed. Rheumatoid arthritis indeed, which is the immune system attacks the joint, beginning with lining of the joint here. This is rheumatoid arthritis, where there is osteocyte deposition. Nearly 1 in 4 of this age group, 40 to 60, have one or the other type of arthritis. Drugs can slow an overtime immune system and therefore reduce the pain and swelling in the joint. The drugs used, as I told you, are called disease-modifying anti-rheumatic drugs. They also include biological therapies. We'll come to that again. Next. In the elderly population, it is basically osteoarthritis, which is a common type. And as we know, it is already a degenerative disease, happens when the tissues that cushion the ends of the bone, that is cartilages, they break down over time. It is one of the leading causes of disease in elderly. You can see hand involved, knees involved, hip involved, spinal cord, and ankles. Next. So to just summarize among the elderly, people who are seeing elderly patient, osteoarthritis is the commonest. It affects hands, spines, hips, knees, but can harm any joint. We already know it is causes because of the cartilage tissue deterioration over time. Rheumatoid arthritis is an immune system which destroys tissue joints. In extreme circumstances, it might even start to harm the body's interior organs. Primarily causes painful swelling in the joints linings. Currently, 1% of the population is expected to be afflicted with rheumatoid arthritis. Infectious arthritis in this age group is basically due to certain types of germs that travel to our bloodstream from another part of our body. More viral infection lasts a week or two and goes away on its own. Next. So, having known the joint, we also need to keep as a general practitioner what are those factors which influence. Basically, the family history. There are some families get these from their genetic son. So one may develop if somebody else has elderly person in the home, you will also develop it sometime with the other. Age, age-wise we saw as age increases, chances to get this bone disorder increases. Women at more risk for rheumatoid arthritis, men for gout. Previous injuries pose extra risk for the joint infection, prevention, particularly sport injuries, accidents, etc. Among the general population, obesity is the main cause which puts pressure on the knees. So gaining weight or the condition of obesity thus might also contribute to developing arthritis. Therefore, the first message we give to our patient is to reduce their weight by 10 to 15% over a period of 3 to 6 months. Of late, two more things have come into picture. Sedentary habits due to lifestyle changes, which is basically negatively impacting our health. They contribute by rising arthritis cases affecting not only the elderly but also young adults. The sitting postures, sitting for long, working only on computers, etc., etc. COVID-19 pandemic also added to this problem. It has given an unforeseen impact on arthritis in India. Lockdown, working from homes, online facilities, home deliveries, mobile addiction, binging, reduced physical activity, all in these 2 years of 21 and 22 led to an increase in the existing patients' problems while catalyzing new cases also. Next. Next. Ankana, next. Now let's go to treatment approaches. I don't know if any one of you are beyond allopathic practitioner, but this is one case where we have an option for integrated management system. So therefore, I will be talking of 3-4 system of arthritis management. Depending upon your interest, you can think of adopting any. First, we look at the allopathic treatment. The general suggestions are using DMARDs, biological response modifiers, glucocorticoid, non-steroidal anti-inflammatory drugs, that is NSAIDs, and analgesics. NSAIDs, this is the oldest approach, which is called as conservative, stepwise approach. We started to use ibuprofen. This is my 57th year of practice. 50 years ago, we used to just give ibuprofen or paracetamol. Then only when progress to more rheumatoid arthritis, if the people showed no signs of improvement or worse damages. The disease-modifying anti-rheumatic drugs, they are include hydroxychloroquine sulfate, leflunomide, methotrexate, tofacitinib, baricitinib, and podicitinib. Biological modifiers are also a type of DMR. They target the part of the immune system response that leads to inflammation and joint damage. They slow the progress of the disease or help for its remission. They are prescribed along with methotrexate usually. Biologic response modifiers are given in injection or IV and they are expensive. The standard treatment today, instead of going in the scaling pattern or escalating problem in the earlier years, the gold standard is what we call as a triple therapy, has a potential meaningful change in the management of rheumatoid arthritis. There are three medications used: methotrexate, sulfasalazine, and hydroxychloroquine to target the arthritic symptoms effectively. The main types of these medications are biophosphates, which slow down or prevent the bone loss, strengthening the bones by inhibiting osteoclasts, which you know are responsible for breaking down and reabsorbing minerals such as calcium from bone and allow osteoblasts to work more effectively. The most benefit happens within the first 5 years of the treatment, and long-term use have been associated with atypical femur fractures, osteonecrosis of jaw, and esophageal cancer. Therefore, bisphosphonates should be given for a maximum of 3 to 5 years, not more than that. Next, steroids, are anti-inflammatory drugs. Synthetic steroids we use, which are called as corticosteroid, either as pills or injections. They will relieve the symptoms and may stop or slow the joint damage. But the side effects, their use should be only for a short period and limited to when the disease flare-ups or DMRDs are not effective. One important thing one has to keep in mind is not to stop this drug suddenly. It has to be withdrawn slowly. JAK inhibitors, both traditional and biological drugs, small molecular drugs, I told you, JAK inhibitors, tofacitinib and baricitinib, are taken orally as an alternative if none of them work. These drugs block specific cytokine pathways called as JAK1, 2, and 3. They do carry risk of getting chronic diseases like tuberculosis and herpes zoster thrombotic episodes. In general, the cost of rheumatoid arthritis or arthritis treatment in India ranges anywhere between 10,000 to 30,000 rupees per month. The average cost of illness was assessed only in 2013 in a small study in Kochi in Kerala, where they said monthly expenditure was in the range of 2,230 rupees. But today we know for 13 and 24, 10-year decade, the value has gone up, and therefore, depending upon even the smallest drug, the cost would be about 10,000 rupees per month. Next. As a general physician, we have the moral duty of alerting our patients about the use of what we call as over-the-counter arthritis supplement. There are a lot of advertisement covering every day. Most of these supplements pose adrenal danger if taken for prolonged period because they contain what are called as glucocorticoid, which leads to iatrogenic adrenal dysfunction or insufficiency, causing Cushing syndrome. But there is an undetectable hormone levels. If you do a hormone test, you will not be able to detect. So, in some cases, there could be symptoms of adrenal insufficiency and can also become life threatening occasionally if not addressed in time. As I told you, any corticosteroid should be tapered slowly. Abruptly stopping can lead to precipitation and replace corticosteroid. So, as general practitioner, we must always ask patient to show the supplement if they are taking any and alert them that why they should not be taking those things. In one of the recent studies of 12 patients, including 4 women, all of them were 52 years, it was shown that all of them had taken these supplements for at least 6 months before leaving, and nearly 40%, that means roughly about eight of them had nausea and vomiting, fatigue, one half of them had about abdominal pain, dizziness. The physical findings showed moon phase in about two-thirds of the cases, central adiposity in the same proportion, abdominal striae in half of them, dorsocervical fat pad in one-third of them, and bruising in one-third of them. 3 of them required intensive care. So the cortisol testing performed in the 11th patient was normal, but an AI was found in 3, while rest had indeterminate results. Of the 7 patients, a subsequent cositotropin stimulation testing suggested an increased cortisol of less than 16 microgram at 60 minutes post-stimulation in 4 patients, while others 2 showed reduced amount but normal responses. 10 of the 12 patients were prescribed glucocorticoid. Later on, tapering was done, and of the 10 cases, 8 continued to take the replacement steroids for another 1 or 2 years. Next. Ankana, next. Now this is just coming to an end. We need to just know as general practitioner what are the surgical therapies and how can we refer suitable cases. The indication for referrals are to be done by primary care provider or secondary health providers in taluk level hospital. What they need to know is a person with osteoarthritis will be considered for joint surgery, but they should have offered at least one non-surgical treatment. So first, you have to say, use some of the treatment already suggested. If that do not succeed, then only recommend. Second, the decision of the surgery must be in consultation with the patient, their attendants, or decision makers in the family, and the surgeon, and just don't go by the Oxford knee score or anything else. You need to consider the referral of joint surgery for people with following conditions: knee pain, knee stiffness with restricted movements, impaired or reduced knee function, substantial impact on their quality of life and activities of daily living, which were refractory to non-surgical treatment. But as a practitioner, we have the responsibility of referring the cases before it is too late and there is a prolonged or established functional limitation and severe pain. Patient-specific factors like age, sex, smoking, obesity, and comorbidities are not the barriers. Please note, they don't come in the way if general condition is good. When discussing the possibility, you need to keep them informed. At least, as I told you, core treatment has been tried, and explain them the possible risks in surgery. Next. Next, please. Next. So what are the surgical therapies? Basically, osteotomy, where the damaged bone is removed and joint surface are scraped and smoothed. Joint replacement is a common surgery, involves the replacement of joint with artificial joint. Nowadays, robotic knee surgery replacement (RKRS) is the commonest. I just had one lady, 70-year-old, coming from a district known as Gulbarga in Karnataka, having taken DMRD for about 3 years. Local orthopedician referred, and we got the done MRI indicated all possible suitable candidates conditions. Surgery was done in Apollo Hospital in Banerghata Road, and believe me, in the first week itself she started walking, and second week without even any support. After about 4 weeks, she was able to join a social function to surprise all known relatives. So robotic surgery has become very result oriented. You can refer your people who can afford. Of course, it costs anywhere between 1 lakh per knee to 2 lakh. But we need to know how to screen the patient and refer them for this condition. Rule out contradiction like severe obesity, if there is any intestinal or bowel obstruction, and inability to tolerate general anesthesia. These are the three basic contraindications to send. Next. Now we come to some traditional treatment. Ayurvedic treatment has given some good results in my two of my cases recently. One was my own spouse, 70 years old, who was under DMRDs for last 5 years, between 18 and 23. Every time she discontinued, the pain used to recur. Since January 2024, she tries using kneecaps throughout the day and apply TRP gel, which is linseed oil, diclofenac, methyl salicylate, and menthol, as you know, overnight. But after hearing in May 24 from a satisfied friend of hers, she asked to allow to be consulting an Ayurvedic treatment. I said I have no problem. What this person prescribed was what is called as herbal ortho pain tablet, 500 is taken only once in the night. The composition consisted of items like shallaki, giloy, chopped chini, ginger, haldi, panamawa, ashwagandha, suranjan, trikatu, and kutaki. These are proportion of these items are not specified on the bottle. Usually it claims relief from the pain from the contents on the box. He also prescribed what he called as lepam powder, which is written in a handwritten on the box with no details of the content. This powder, a spoon of it was supposed to be converted into a paste using egg white and applied on the knees affected and left overnight to be cleaned in the morning. To my surprise, the first 2 weeks she found that the pain and stiffness had reduced, and in the last 8 weeks she gets about 50% relief from what she was. She is able to move about without kneecaps, without any other allopathic drugs. In our recent visits to Goa, she was able to walk on the sand, which was impossible earlier, on the beach, and she was also able to go up the steps, about 10 steps, with comfort. Seeing this result, I referred another patient, a male, age 68 years, and this person also has reported a 20% relief in a period of about 3 to 4 weeks. His prescription include what is called a Sandhi Sudha tablet once daily and Rasayana Kata Churna to be boiled in water and consumed, tablet Anuloma for constipation. Again, as I told you, he has reported a reduction of 20% within a span of about 3 weeks. So these appears to be promising. It is left to the individual discretion of the patient and the doctor. Next, next, Ankana, next. There is also lots of drugs in homeopathy treatment. I have 3 patients who are using some of these permutation combination I have just listed. Basically, these are drugs which are supposed to be anti-inflammatory. Most of them are herbal drugs. So with the 2 cases, marginal benefit, I would not watch as it stands today from my own experience. But there are people who do recommend this. Next, please. Now, another traditional method is coming back from our traditional thing. I don't know how many of you know. This is known as cabbage leaf packing of the affected joint. I have tried in the last 2 months on my own 2 patients, and in about 4 to 6 weeks, there is a reduction of pain and stiffness of 25 to 30%. The literature says it should be done for 1 hour, and there is also a study which I'm going to refer soon, 1 hour per day. But what I tried was covering or wrapping the affected knee with cabbage leaves soaked in ice cold water for 2 to 3 hours, apply before going to the bed. Since they would fall, wrap them and over that tie a piece of bandage or paper or a sticker so that the person when asleep, it does not sleep over. Again, I am confident that in the earlier stages, these may also help. There is a study reported where patients in grade 3 and 4 of the KL grading system, which we had already seen, this study has a blind control with 3 groups. In one, a cooling gel pack was used for 20 patients. In another, diclofenac gel was used. And the third category, the cabbage leaf, they had used for 1 hour duration. All the participants were trained to do the numerical assessment in the format which I had shown, how to rate them according to their self-experience, planes, etc. And the data was analyzed using what is called as a paired t-test or ANOVA, analysis of variance. The result indicates that the cabbage leaf group and cooling gel showed a significant difference in both Oxford knee score, significance at the level of 0.001, and NRS score also, after the intervention by using the paired test. Therefore, the study had concluded that cabbage leaf application and cooling gel showed similar results in reducing the osteoarthritis symptoms. Both methods and their therapeutic effectiveness was better than diclofenac gel. Next. Next. So finally, I come to the role of various things which we can do as general practitioner. Early detection is critical in arthritis management. This plays a pivotal role in dictating the course of disease, ultimately the patient's quality of life. Early medication, prompt diagnosis based on the drugs which we already discussed. Second, lifestyle changes Basically, exercise regimen and dietary modification are effective. These strategies often reduce the need for aggressive medical treatment down the line. We also know that because of the pain, people do not exercise, it increases. So it's a vicious cycle. So we need to manipulate and ask them to start doing some exercise so that they reap some fruit. And optimal management include early detection and active disease monitoring, regular checkups, diagnostic tests if required, and ensuring optimal management. Psychological impact is also very important. Therefore, psychotherapy of these patients, what we call as a positive psychological therapies. Now, what happens is there is a mental depression. Most people get depressed. So, their stress management, if we can use, there will be a proactive approach to the disease management. Next, rounding up, summary, executive summary, you can say there are roles for individuals, we, the primary care providers, and the government. As an individual, self-care, losing weight 10 to 15% in 3 months, switching from high-impact activities like running to low-impact activities like walking and swimming, particularly as age advances, avoiding movement like lunges, squats that could make the condition worse if there is already mild condition. If arthritis is, people may not feel like exercising. However, being active helps to reduce and prevent pain. Regular exercise improves muscular power, movement, and joint mobility. Apply ice or heat or cabbage leaf for pain. If not relieved, let them come to you and you can decide on what NSAIDs or DMRDs to be given. We as family care physicians need to take detailed history, do a thorough physical examination, use scanning and MRI if required, and diagnose as early as possible. OKS, Oxford Knee Score, is easy to use and will be helpful if you keep trying. Refer the case first thing if you think it is worth going for and some drugs have already been tried. Encourage the patient to stretch often, which will help decreasing stiffness in the joints. Remind the patient to use their strongest joint first and encourage them to sit in chairs with arms so they can push up when getting up. Ensure the patient maintains a good balance between rest and activities. Finally, the national government now has to come to the rescue given the magnitude of the problem in the country. Train more doctors, physiotherapists, nurses, community health officers, and paramedicals to diagnose and manage rheumatic disease at the primary level, of course, at secondary and tertiary level too. Probably my last recommendation for the government would be to launch a community-based national healthcare program to manage RMSK diseases, rheumatoid and musculoskeletal conditions at the community level, particularly health and welfare center, PSCs, CHCs, and taluk hospitals. Next. These are the references. Next. So basically, I am requesting all of our friends first to evaluate all patients, potentially impact the early diagnosis and if required referral. Early referral should be considered if the patient has an inflammation, active inflammation and more than 2 joints are involved and if the pain is lasting for more than 6 weeks. This is especially important when a surgery is required. Thank you all. and through Arpita.
Thank you, sir. Thank you so much for the valuable talk, sir. Thank you so much, sir. So with this, we would like to conclude the session here. Thank you so much. Thank you, sir.